Thank you, Mr. President and ladies and gentlemen. I'd like to thank you again to the audience in this room and also presented online. Dr. Go introduce yourself, please.
Good morning, everyone. My name is Jeong-Wook, and I'm a professor at Department of Pathology in Seoul National University Hospital. It's a great honor to be here and talk about the normal anatomy of heart.
Yeah, let me show these two beautiful specimens. Can you show this specimen from the back? These two specimens, as you can see, are shape of heart. This one is a cast 3D printed heart of the wall of the heart, and this is the chamber of the heart. So the clinical images usually show either the chamber of the heart or wall of the heart. The chamber shows the superior vena cava, right atrium, right ventricle, and pulmonary trunk, and the red colored printed part consists of oxygenated blood filling area, pulmonary vein, left atrium, left ventricle, and aorta. In this particular specimen, I'm showing a beautiful demonstration of this defect of the images, which in fact is the very much thickened left ventricular wall due to the hypotrophy cardiomyopathy. In this specimen, we can show how the aortic outflow is narrowed due to the mitral valve leaflet and so on. And if you go to this specimen, I'm showing the sternum first and superior vena cava, right atrium. And if I cut like this, I show the right atrium, right ventricle, aortic valve here, and left ventricle and left atrium. And also, we can cut further to show four-chamber view of this specimen, right atrium, right ventricle, left ventricle, mitral valve, and left atrium. I mean, these are wall of the heart, but in fact, they consist of myocardium, fatty tissue, and pericardium. We don't show exactly how it consists of how is the fibrosed in this area. So it's still very important to understand the real cardiac anatomy based on the real heart specimen. So let me show this heart from this heart first. In this small heart of baby from autopsy, I can showing right lung, left lung, and in the middle mediastinum, you can see the heart and show superior vena cava, right atrium, right ventricle, pulmonary trunk, and pulmonary vein, left atrium, left ventricle, and ascending aorta. The neck and arm vessels are in this neck area and in front of the trachea and so on. And if you look from inferior, we are looking at the heart after removal of the liver, and shows the opening of inferior vena cava, and four lower pulmonary veins are draining to the left atrium like this. And I remained a little bit of pericardium to here, but I can show better with this specimen. Pericardium is a very important structure for the heart to protect the heart from the surrounding tissue, and it is a membranous tissue, but it is strong to protect the heart from the rest of the thoracic organ. But also it harbors the nerve, phrenic nerve, and left phrenic nerve here to supply the diaphragmatic muscle, and also on the right side, we can show right phrenic nerve to show at the area near the superior vena cava on the right atrium. And also from this cut, we can see the right lateral side of the heart to show pulmonary veins, pulmonary artery, and trachea, right trachea, and so on. And also, this is descending aorta, this is esophagus. From the left side, we can also see the left trachea and left pulmonary artery over the left bronchus, pulmonary artery, left pulmonary vein, and so on. And also, at the inferior side, we can see oblique sinus pericardium, which is a part of pericardial space like this, so that we are showing left pulmonary vein, right pulmonary vein and IVC, and surrounded by this upper pulmonary veins and so on. This is oblique sinus pericardium. And also, after removal of the parietal pericardium, you can see the transverse pericardial sinus in the back of the aorta and pulmonary trunk, in front of the right and left atrial chamber. So these are the basic structure of the heart. And in this particular specimen, I'd like to show four-chamber view of the heart to show I cut the heart in parallel plane of the diaphragm so that I show the base of the heart or inflow part of the heart. So this is right atrium, inflow to right ventricle through tricuspid valve, and here is the left atrium, and inflow to the left ventricle through mitral valve. So I can show posterior lateral papillary muscle here. Anterolateral papillary muscle here. And in this particular specimen, the left ventricle is markedly dilated due to dilated cardiomyopathy, which is the cause of the death in this patient. So just in front of this sectional plane, we can see the aortic valve just in front of the mitral valve. So if you make a section just above this plane, we can see ascending aorta together with these four chambers.
Dr. Sir, can I ask a question?
Yes, please.
Recently, we have lots of redo operation.
Yeah.
And after the operation, diaphragm pulse is not rare. So you pointed out the course of the phrenic nerve. So Dr. Lee may mention about how can we can avoid the phrenic nerve damage in this specimen.
I just saw the phrenic nerve in that specimen. Can you show us the
Specimen, please.
Yeah.
Okay.
Yeah.
Yeah.
That is left phrenic nerve.
Yeah.
So actually, we do the reoperations. Actually, in some patients, we couldn't see any phrenic nerve structure around there. Right. Yeah.
Oh, yeah.
Right side phrenic nerve there. Yeah. Yeah.
Okay.
Thank you. Yeah.
So they are rather symmetrical, but the heart is not symmetrical. So the right phrenic nerve goes along with the SVC and some similarity to sulcus terminalis, and left atrium, it is near the left atrial appendage and lateral wall of left ventricle. And it is also clear that inside of the heart is nothing with the phrenic nerve, but it is attached to the outside of the heart, tightly attached to the pericardium.
So also in the redo operation, we sometimes encounter the constrictive physiology because of the pericardium itself constricted the heart dilatation. So the surgeon tried to decorticate the pericardium, but after the operation, the constrictive physiology did not appear. So
So it's pity that after operation, sometimes, not always, the visceral and pericardium adheres together so that there is a little space in the pericardium, and by accumulation of fluid, it makes a tight pressure within the pericardial chamber.
Okay. Tomorrow in session 4, we will discuss about the redo operation, many complications, such like phrenic palsy and constrictive physiology. Okay, thank you.
All right, thank you. We can go inside of the heart to see the details of the anatomy of the heart. This is SVC, and this is right atrium. And here we can barely see a line between the smooth part of SVC in continuity with the sinus venerum part of right atrium, in contrast to the free wall of right atrium, which has pectinate muscles. Of course, it's not really possible to demonstrate the difference between the two, but in this specimen, we can understand the little fatty tissue in here, which is an area of a sinus node. Almost exactly the location of sinus node is like this. So it is on the sulcus terminalis, which is the line or groove between the sinus venerum part and right atrial appendage. And if you go inside of this part, you can see the crista terminalis. This is crista terminalis, which makes a difference between the pectinate muscle area, which has a very thin, paper-thin myocardium and rather thick myocardial bridges as a pectinate muscle, and the lateral to the crista terminalis is a sinus venerum part, which is an extension of a superior vena cava blood vessel. But still, they have myocardial cell in addition to a little bit of smooth muscle layer of blood vessels. And at the wall of the right atrium, we can see the atrial septum, which has an oval fossa, which is an oval or kind of horseshoe-shaped ridge surrounding the oval fossa. So in the physiologic, embryologic, fetal blood flow, IVC blood goes past through the ASD to left atrium like this. So the border of sinus atrial septum or border of oval fossa is a border to protect the IVC blood to go to left atrium, which is oxygenated blood from the mother to enter to left atrium, and then to left atrium and to aorta to supply brain first. And then systemic venous blood flow inflow comes from the SVC to go to right ventricle and pulmonary artery, which is going pulmonary artery and then through ductus to descending aorta to return to the mother through umbilical artery. So that's a fetal physiology, but the adult cardiac anatomy makes some history in the fetal life to make this shape. And also, if there is a patency here, we call patent foramen ovale, which is closed when the left atrial blood pressure is higher than right atrium. But still, when the right atrial blood pressure is higher, in pulmonary hypertension, it makes a reversal of the pressure difference so that right atrial blood go into the left atrium. So venous non-oxygenated blood make blood flow through to the left atrium and so on. So the atrial anatomy is important for atrial septal defect, which is one of the main causes of adult congenital heart disease, and which also can be treated by umbrella device to close this ASD. As you can see here, there is a coronary sinus, and in the coronary sinus is here, and there is a little valve-like tissue, which is a Tevesian valve, and that makes a can you enter? Okay, good. So that's coronary sinus orifice. And also here is the eustachian valve, which is in front, is a continuation of crista terminalis in front of the IVC. So these two valve-like structure together makes a commissure-like structure here to make a starting point of tendon of Todaro, which is a kind of tendinous structure from the membranous septum to here, and that is the border of a triangular cohort, which is this tendon of Todaro, orifice of coronary sinus, and tricuspid valve septal leaflet, and which is the area of atrioventricular node here. So we already see, so the septal leaflet of tricuspid valve, which is tightly attached to the ventricular septum of right ventricle, and the anterior and posterior leaflet of tricuspid valve makes 3 or sometimes 4 and 5 leaflets of tricuspid valve. In this particular specimen, there is a tight breaching muscle between the septum to the free wall, which we call moderator band, which is a septoparietal band. One of the thick septoparietal band is we call moderator band. And from the outside, you can see the papillary muscle of Lancisi, which is a papillary muscle between the septal and anterior leaflet. This particular papillary muscle is very small or tiny when VSD is present or congenital anomaly is present. So the presence of the thick papillary muscle means this is a normal heart. This is a pulmonary valve and subpulmonary muscular structure we call subpulmonary infundibulum, which is described because with the apex of the pulmonary artery, we have a triangular or conical shape of the right ventricular outflow chamber. So infundibulum or conus have the same name to describe this area. But in some sense, the infundibulum or conus describes the presence of muscle between the pulmonary valve and tricuspid valve. So presence of this particular muscle we call infundibulum or conus. And also we described it as a tricuspid pulmonic fibrous discontinuity, which is different from the mitral aortic fibrous continuity. So this part is called crista terminalis, crista supraventricularis. But there are so many different names. Some of them are from embryologic origin and some are morphological origin. And also ventricular infundibular fold is another name of this area, and septal band is another name. So we have to know everything, but we should understand what they call this area and so on. And also the term septomarginal trabeculation is this part, septomarginal, which is in the anterior part of the right ventricular area of the septum. This is septomarginal trabeculation, thick part of muscle tissue, anterior part of the right ventricular septum. It has an anterior limb and posterior limb, and between them there is a papillary muscle of conus or papillary muscle of Lancisi, so it's Y-shaped. When defect is present, it usually has here. So between the anterior and posterior limb of trabecular septum marginalis. Pulmonary valve is rather simple because there is no coronary orifice in this area, but it has a 3-leaflet valve, or sometimes it makes a 2-leaflet valve when the pulmonary stenosis present, or some underdevelopment of pulmonary valve makes a pulmonary vascular stenosis, and so on. From the left side, we can see the left atrial chamber, which is a little different in right atrial chamber. The difference is the absence of a pectinate muscle in the main part of the left atrium. So inside of the left atrium is clean and smooth, and the endocardium of left atrium is thicker than right atrium. That is normal. And also, we can see the other part of the oval fossa, which is here. We don't have limbus in this side because the limbus of oval fossa is right atrial structure. We have just a thin membranous part of atrial septum. Here we can see the opening of left atrial appendage, which is from the outside. It has this shape, finger shape, and so on. This left atrial appendage is derived from proper left atrial chamber, and the rest of the left atrium derives from the pulmonary vein. Pulmonary vein connects to the embryonic left atrium, and the pulmonary venous chamber becomes larger to occupy the most of the left atrial chamber in the normal development. The mitral valve is very peculiar shape in the sense that there is a big anterior leaflet. It is triangular, and this is the annulus of mitral valve. So it is thick fibrous annulus of mitral valve, anterior leaflet mitral valve, and the rest of the mitral valve is posterior or mural leaflet, which makes 3 or 4 scalloped valve tissue, which means as you can see, normal anatomy of valve shows commissure, leaflet, and chorda, and papillary muscle. Here, the commissure between anterior leaflet and mural leaflet is this papillary muscle, this anterolateral commissure, and with anterolateral papillary muscle, and this is a posterior medial papillary muscle at the posterior commissure here. So the shape of coda is peculiar in this area, so make a fan-shaped commissural papillary muscle, and also there are free border codals to make mitral valve tight. So the shape of coda papillary muscle and leaflet of left mitral valve is important to protect the mitral valve leaflet from regurgitation. So when one of these tissue are teared, it makes a mitral valve regurgitation. And also, if you go inside, you can now clearly see the difference between the mitral and tricuspid valve, that there is no valve tissue attached to the septal part of left ventricle, in contrast to the mitral valve and tricuspid valve and right ventricle. The area is tightly attached. Tricuspid valve is attached like this, but mitral valve is freely demobilized from the septum to make this anterior leaflet. The anterior leaflet is also called aortic leaflet because it is in continuity with the aortic valve, and this is ventricular septal surface of left ventricle, and so on. So to understand the anatomy of the aortic valve, it is very good to understand the the surrounding structure surrounding the aortic valve leaflet. This part is left atrium, and this part is left ventricle, and anteriorly it is subpulmonary infundibulum, and which we will discuss a little bit later using the sectional view of this heart. Before we move to the sectional plane, I'd like to show the coronary arteries. I produced this specimen by infusing silicone tissue to the coronary artery and fix it, and we can see the coronary artery. Coronary artery is usually not exposed like this, but fat tissue covers over this coronary artery, but in this specimen, I removed the fat tissue. So this is right coronary artery in the right coronary sinus, and right coronary artery runs between the right atrium and right ventricle, and make to posterior to run into the posterior descending coronary artery. And there are muscular branches to right ventricle, and some of them has name, some of others don't have name. This is we can call infundibular branch, which covers infundibulum, and this is acute marginal branch, which covers margin of right ventricle, which has an angulated margin, acute margin between the anterior chest wall to the diaphragm. And there is a sinus in AV nodal artery, which we can see here. This is AV nodal artery. It goes to the AV node through this artery. And from the left side, we can see left main coronary artery from left coronary sinus. It branches to left anterior descending and left circumflex artery. There is a very short common left main coronary artery, and also we can see sinus nodal artery in this specimen. Sinus nodal artery may have origin from here, or the other heart we may have from here. So it directs to the sinus node area, which is in here. So it may come from left coronary artery, or it may from right coronary artery. So this is left circumflex coronary artery, left anterior descending coronary artery. This is in diagonal artery, first diagonal, second diagonal, third diagonal artery, and so on, to describe the artery to the free wall of left ventricle. And also there are several perforating branch to the septum, and which we can demonstrate not in this specimen, but in other way. So here we can clearly see this zone, subpulmonary infundibulum, is free of major coronary artery, so we may cut, but we don't have to. If possible, we have to make this part free of any surgical incisions to maintain the cardiac function. And also, we describe this acute margin, but this is obtuse margin, which has an obtuse marginal artery, which supplies papillary muscles and left lateral wall of left ventricle. These are coronary sinus. Coronary sinus is usually over the left circumflex artery like this. So, and also we have already discussed the phrenic nerve is around here in pericardium. So the procedures doing aortic valve surgery or arrhythmia and coronary sinus intervention may damage the phrenic nerve and so on. It may be temporary or it may be irreversible. So these are the outside. These are specimen of base of the heart, which we are looking at right atrium after removal of free wall of right atrium, and this is left atrium, and we are looking beautifully the mitral valve from the left atrium. So mitral valve anterior leaflet is like this. So it has the anterior leaflet, and it makes an opening like this. So this is free wall. So the normal mitral anatomy makes this shape so that blood filling from the left atrium to left ventricle is like this, but they go to the aorta to make a very efficient flow to the ascending aorta through aortic valve in front of mitral valve. But if the mitral valve is stenotic and regurgitant, it may some ineffective ventricular filling and so on. So from here we can see 3 aortic leaflets and 3 commissures. In contrast to the atrioventricular valve, the aortic valve commissure doesn't have coda and papillary muscle, but they have a line of commissure and nodulus auranti to make this valve competent. And also, you may have already recognized that these commissures are facing the pulmonary valve. So there are 2 facing pulmonary valve, facing coronary cusps, facing the pulmonary valve. So this is right coronary cusp. Right coronary artery arises from here, and left coronary cusp arises here. Right is here. Yeah. Coronary artery is not in the deep part of the coronary sinus, but it's near the supra-aortic ridge, so that it makes the sinus part is the blood filling area to close valve leaflet, and also the coronary arterial blood has no effect from the fast blood flow from the aorta. And also left coronary artery is here, and this is non-coronary cusp, and no coronary arteries in this area, in the normal heart. But clearly, in heart specimens with there are variations of coronary arterial anatomy, particularly in case of transposition. It is in front of this area, so it is important to individualize the anatomy of coronary artery in a certain disease specimen. This is pulmonary artery. And so this aortic valve is in the center of 3 valves: mitral valve, and tricuspid valve, and pulmonic valve. Pulmonic valve is a little bit left anterior to the aortic valve, and so that right ventricle and pulmonary artery has a banana shape, or this shape, and left ventricle has this egg shape, or round and oval shape, and so on. So if you look from the apex, which is more comfortable for cardiologists, because the looking at from this direction is usual for clinical images. So this is mitral valve, anterior leaflet of mitral valve. And posterior leaflet. So, yeah. And also aortic valve is shown here, and tricuspid valve is here, and aortic valve is here. So, and the ventricular septum, you have recognized that ventricular septum is a part of left ventricle rather than part of right ventricle. But right ventricular wall is here, and a part of ventricular septum is in continuity of right ventricular wall. and so on. And also we can see mitral, aortic, fibrous continuity, and tricuspid pulmonic infundibulum. And from the aortic valve, we can recognize the adjacent structure. Anteriorly, it is pulmonic valve, and right lateral and posterior, it is left atrium, and to the right side, it is the ventricular septum. Membranous septum is here, and that is also the area of conduction tissue going into the left ventricle. This is the heart viewed from the anterior, and if you make a section from the long axis, which means long axis of the heart means from the left ventricular apex to the aortic valve. So we are the junction between left and right ventricle is here. We can recognize it through the left anterior descending coronary artery. And so this part is left ventricular apex, and this part is right ventricular apex. So if you cut from the apex to the aorta, we can show like this. So that this is the left ventricular inferior wall, and anterior wall, and subpulmonary wall, and this is right subpulmonary infundibulum, and also that is subpulmonary infundibulum, and here is aorta with right coronary artery and left coronary artery, and so on. And this is mitral anterior leaflet in fibrous continuity with aortic leaflet, which we can see both aortic and mitral valve, which are most important valve clinically as a disease function. And also you can see left ventricular contraction from this view. Clinicians, cardiologists can make any different cutting plane of the heart, but that is freedom of cutting the heart without destroying the cardiac function. But we need to have a standardized viewpoint to show the good view of the heart specimen. And this is one of the favorite view from the cardiologist, which shows right ventricle to pulmonary artery, and aortic valve is here, and this is left atrium, and this is anterior leaflet of tricuspid valve, and this is right atrium. So it's beautiful to show aortic valve in the center, and maybe like this. So this is left atrium and mitral valve, right atrium, and pulmonary artery surround right atrium, right ventricle, and pulmonary artery surrounds these two left-sided cardiac structures. So this is the end of the normal anatomy. Is there any comment? Yeah. So we will go to VSD. I'll show this specimen first. This is also clinical CT, the 3D printing based on CT scan of the heart. I made a window of right ventricle, right atrium, ascending aorta, and pulmonary artery. I show the VSD in here and a little bit of narrowed subpulmonary part, which is a variant of VSD, similar to tetralogy, but still the subpulmonary infundibulum is enough so that it is a kind of VSD rather than tetralogy. And also from the left side, I made a window to the left ventricle to see the VSD and aorta and so on. And in the back, I made a hole in the rib and spine to show left atrial opening to inside of the left atrium and descending aorta. We don't have to do every cardiac specimen, but we can produce this kind of shape to demonstrate the cardiac morphology. And good thing is we can show heart pulmonary vessels and surrounding structure, neck and arm vessels in addition to cardiac shape and so on. And in fact, this is doubled the original size to show better of the heart specimen. So I can make several more to give you a gift to explain the patient or other clinician to make them understand the anatomy of the heart. This is the introductory part of the specimen review, but I'd like to show some tips of examining heart specimen in your lab. So this is a mobile phone with specimen. When you examine the specimen, it's good to show like this to view. Also, we can see with the bare eye, but also you can see through the smartphone and take picture with this. And also you can use mobile video images of the specimen, and that can be your own property to use when you present some lectures and so on. Do you recognize any specific the importance of this specimen? Yeah, I'll show. This is how you can use this view using your specimen during your workshop. But in this, I can better view with direct imaging of this case. So this is a VSD case, but there is a prominent muscular ridge on the left side of the VSD, so that the subaortic part is a little bit narrowed due to posteriorly deviated outlet septum. So sometimes this aortic valve may be bicuspid or small tricuspid valve, tricuspid aortic leaflet. So this is the left ventricular contraction makes aortic blood flow, and also shunt to the right ventricle is prominent. So this posterior deviation of mitral valve can have to be recognized when you examine these kind of cases. So it is the pulmonary valve is big enough, and aortic valve is less developed in this specimen. And also sometimes coarctation or narrowing of isthmus of aortic arch and combines these cases, and also in this case post-stenotic dilatation of ascending lateral part of ascending aorta makes a bulging aortic area. So if you don't examine the aortic valve properly, we may misunderstand the aorta is big enough to make a normal aortic blood flow, but that is not true in this case. And also another tip in the specimens, you can scan this QR code, and then you will see the video explain this specimen. So when you examine at the workshop, you can use this technology. Let's look at this. It is another example of right ventricular hypertrophy, and VSD is here, and from the left side, the similar morphology to the previous case, so that the subaortic stenosis make a small aortic valve and posteriorly deviated infundibulous septum in this heart. And also there was a coarctation and interruption in fact, so that the surgeon cut the ductus, the continuing right ventricular ductus and descending aorta, and ascending aorta covers only neck and arm vessels. So this ductus is cut and connected to right ascending aorta. This is 3 minutes left for 4 minutes. So I can explain every heart specimen, but it's better for you examine by your own eyes to show, to understand the anatomy of these different heart specimens. So these are AVSD cases with different morphology. So every single case have different morphology, and this is non-operative specimen and better to show the characteristics of AVSD. So in this specimen from the right atrium and right ventricle, this is superior bridging leaflet, and important thing is the atrial septum descend to the ventricular septum area, but it is stopped here. And mitral and tricuspid valve are in continuity with each other to make a bridging leaflet, anterior bridging and posterior bridging leaflet. So it's this single defect connects 4 chambers, left atrium, right atrium, left ventricle, and right ventricle all together. So it's AVSD. It is still very functionally patent because the atrial contraction and ventricular contraction are working together. So common AV valve, atrioventricular valve, makes a competent contraction between atrium and right ventricle in the very young age period. But by becoming older, the difference of right and left ventricle and right and left atrium makes the problem in this defect, and so on. This is coronary sinus orifice, but the triangle of Coho, which we described already, that in the heart with separate mitral tricuspid valve, which is AV node was here, but in this particular specimen, it's clearly it's not possible to locate coronary sinus atrioventricular node in this area. But AV node is displaced to back to make a long conduction tissue from this area. So it is important to understand the anatomy of atrioventricular septal defect when the surgeon make a septation of this part. Otherwise, the left and right ventricular wall function is normal. So by operation, it's still very curable disease, and so on. So these are the specimens I can show today. So those rest of the specimens are your observation, and I hope you enjoy in the specimen. And also finally, I'd like to show some safety precautions due to the coronary epidemics. And so we prepared this face shield. Face shield has too thin covering from both sides, so we have to remove this first, and the other side remove, and then we can use like this. I feel it's not very uncomfortable to use this face shield, and so in the next room, when you examine this specimen, it is recommended from the protection of yourself and your colleague. But I know we are all vaccinated people, but still we have to show some precautions. And also we prepare this gown to protect yourself and your body. So thank you for your attention.